Watching. Yeah, okay. Thank you. Let's okay, so hi. Yeah, so welcome everybody who's here and to those of you who are watching the recording. Um, so yes, welcome to the June Journal Club and so Dr. Nidhi Yadav is going to present this paper on myofascial pain syndrome. And then we will have a bit of a discussion afterwards about the paper and various aspects of how it's been put together. So, Dr. Nidhi, thank you very
Yes,
much
sir.
for the presentation.
Thank you, sir.
The all yours.
Thank you, sir. Can I start, sir?
Yeah, please do.
Yes, thank you so much. My name is Dr. Nidhi. I will be presenting a journal club on topic expert consensus on the diagnosis and the treatment of myofascial pain syndrome. So I will be starting with the journal. What is this journal is about? This article is published by Qi-Wang et al. He published this article in a World Journal of Clinical Cases. This is a peer-reviewed and an indexed journal. This is indexed in PubMed, Embase, Web of Science, and it is. Uh, can I continue, sir? Yes. This is a modest citation impact journal. It is not at all considered as a top tier high impact pain journal. But since this is an expert consensus rather than an original research or a systemic review, its evidence level is generally considered moderate to low in evidence hierarchy depending on how the consensus was developed. So, about authors, this article is published by 16 authors, mainly from pain medicine, orthopedics, and physiology department. These are generally a Chinese clinicians and a pain specialist. They have done a multi-center contribution from China. The critic point for this article is because most of the authors are pain physician from the China. The recommendation may reflect the regional clinical practice pattern and may not represent global multidisciplinary consensus. So, what is the purpose for this paper? The the article is published by a pain specialist and a clinician. So, their main motive for this article is they have in standardizing the diagnosis and treatment of MPS, and they have provided the practical guidance for frontline pain physicians. They have addressed lack of unified diagnostic criteria for MPS. The paper explicitly states the consensus was intended to normalize the diagnosis and treatment of MPS for especially the first line doctors. And they have no specific laboratory and imaging markers, but frequently that is misdiagnosed. The main aim for this article is to standardize the diagnosis and treatment of MPS, and that we in this article they have mentioned about expert consensus. So this consensus is organized by Chinese Association for the Study of Pain. So I will be starting with the main contents. That is, first of all, introduction. So, starting with the myofascial pain syndrome, that refers to the type of a chronic pain syndrome that recurs in a muscle, fascia, or related soft tissues and can be accompanied by various emotional disorders or psychosomatic disorders and dysfunctions. This is mainly characterized by an myofascial trigger points and facial constrictions. The trigger points are sensitive to stimuli, causing localized pain or referred pain. MPS can occur alone or in combination with any other diseases. So they have mentioned that this article has been the myofascial pain has been proposed by American scholar called Dr. Trevell in 1952. As this myofascial pain syndrome gained more popularity because of its other names that has been named as myofasciitis, facial fibrositis, myofasciitis, fibromyositis, muscle strain, myofascial syndrome, that has attracted more and more attention towards the clinicians. Coming to the etiology, as the etiology is not very well known and or very well not completely understood, but in this article they have mentioned that The allogenic substances such as bradykinin, prostaglandin, histamine, serotonin, and substance P play a key role in the etiology of myofascial pain. They have also given an hypothesis that there is a stimulation of some sensory nerve fibers because of allogenic substances that cause an inflammatory environment and later cause compression or an inflammatory edema for the tissues that leads to the MPS. Other thing they have mentioned about the ergonomics, that is the posture. The like office workers, musicians, dentists, and other occupational groups, those have an poor ergonomics that can develop MPS. Also, they have discussed about the metabolites accumulate to stimulate some peripheral nerve endings that cause a sensory nerve dysfunction, which will lead to referred pain, hyperalgesia, and allodynia. Coming to the myofascial trigger points, there are some predisposing factors and risk factors they have discussed about. That is acute muscle injury, some mental stress, over fatigue, intense cooling of muscle, some hormonal changes like hypothyroidism, menopause, nutritional deficiencies, vitamin B or iron deficiencies, some chronic infections, local chronic instabilities, and immune diseases that can cause myofascial pain disorders. They have also mentioned about epidemiology, where they have described about 30% to 93% of patients are suffering from mucoskeletal pain, and about 46.1% of the patient have an active myofascial trigger points in the physical examination. Also, there some clinical studies shows that 40% of skeletal muscle pain syndrome is mainly because of activated points in a painful muscle. So, they have described a little bit about pathogenesis as well. They have described there will be there can be an initiation of myofascial trigger points, which can be due to an abnormal increase in the acetylcholine in the motor at the motor end plate. There can be muscle contraction that can be enhanced by traumatic. Microtraumatic condition can be acute or chronic overload, energy consumption or ischemia. Induction of pain can be caused due to nociceptive substances, as we have discussed before. Spread of substances, referred pain, and some central pain sensitization that increase the excitability of neurons and expansion of neuronal receptive fields, leading to refractory referred pain. Coming to the symptoms and signs, some common symptoms for myofascial pain syndromes are pain that can be regional pain, burning, jumping, numbing, sensory abnormalities, persistent paroxysmal, aggravated by cold, fatigue, muscle overload. There can be stiffness and limited range of motion. There can be dysautonomia, that is segmental sweating, chilling, pallor, proprioceptive disorders like dizziness, tinnitus, imbalance, or depression. Because of the repeated visits, patient can undergo to anxiety or depression that can cause a lower pain threshold level that can cause intensify the pain. And dysautonomia that cause poor sleep and caused by night pain and morning pain. Some common signs are restricted movements, taut bends. I will be discussing more about taut bends, painful nodules and ropes, and other types of myofascial trigger points in a further slides. There will be a tenderness on compression and cause local pain, and there can be a local twitch response, temporary contraction of a muscle fiber in a taut bends associated with myofascial trigger points that can be triggered by plucking, palpation, or acupuncture at the irritation point. So, this is what I was talking about. They have given a diagrammatic representation for a trigger point complex. So, they have shown a shaded cord-like area within a muscle that is known as a taut band. This taut band is palpable clinically during a physical examination. This is nothing but it is a muscle, contracted muscle, or a sustained, when a muscle undergo a sustained contraction, this becomes a taut band. Other thing they have described in this diagram, that is CTRPs, that is central trigger points, and ATRPs, that is attached trigger points. Central trigger points are in hyper irritable areas that when get palpated, it cause and referred pain, that is pain occurs other than the actual site, or when there is a sustained stress or when there is a sustained contraction, this central trigger points uh, get activated, and later that will convert into an attachment trigger points that cause a local pain. So whenever any myofascial pain syndrome patient is there, whenever we palpate, for example, if we palpate a masseter, that it will cause a local pain because of an activation of attachment trigger points. Or if we palpate and central trigger points, it will cause a referred pain. For example, if a masseter is palpated, some patient will tell that pain is causing a toothache pain or a ear pain kind of pain. So it is because of a activation of the central trigger points that cause referred pain. So they have given this integrated hypothesis where they have explained that abnormal acetylcholine increase can cause increased fibrous tension that lead to the taut band formation, later cause local hypoxia, tissue distress that leads to decrease in ATP, release of some sensitizing substances, and later cause pain, and further cause autonomic modulation, and this cycle will continue. So the diagnosis, as we have already discussed about symptoms and signs in the previous slides, I will be discussing about auxiliary examination that this article, the author have given in this article, that is imaging examination, the X-ray, CT, USG, MRI for musculature, myofascial assessment for location, shape, size, depth, elasticity, nodes, calcification, extensive studies on USG and MRI. He have also explained about infrared thermal imaging that I will be discussing in the treatment part, elasticity measurement that assess the using special tools for local myofascial elasticity. So, in this article, as they have told that myofascial pain syndrome is a complex disease that can be misdiagnosed with other type of similar diseases. So, they have given differential diagnosis. So, myofascial pain is easy to confuse with many diseases with similar clinical symptoms, and it should be distinguished from the following diseases. The first one is a fibromyalgia. It causes a general pain, physical discomfort, fatigue, sleep disorder, morning stiffness, depression, or anxiety. So, how to compare with myofascial pain syndrome with fibromyalgia? In fibromyalgia, generalized pain without obvious myofascial trigger points are there. That means fibromyalgia does not have any myofascial trigger points, but in myofascial pain syndrome, there is a localized pain. There is a localized pain with painful myofascial trigger points that cause referred pain on palpation. So this is the chart they have mentioned the difference between fibromyalgia and myofascial pain syndrome, which is most common in females. The range of pain is generalized in fibromyalgia, but it is relatively limited in the myofascial pain syndrome. While injecting a local anesthetic to myofascial trigger points, there will be no relief in fibromyalgia, but there will be a significant result in myofascial pain syndrome. Myotonic rigidity is generalized in fibromyalgia, whereas it is local in myofascial pain syndrome. Fatigueness and sleep disorder is usually present with fibromyalgia, but it is absent in myofascial pain syndrome. Coming to the another differential diagnosis, that is polymyalgia rheumatica. It is generally it causes a symmetrical myalgia, stiffness in neck, scapula, pelvis, mild tenderness, mostly seen over 50 years of old patient, and the diagnostic indicator is increased ESR and C-reactive proteins, and it is very well treated with the help of corticosteroids, which can be used as a diagnostic criteria. Coming to chronic fatigue syndrome, which is a Center for Disease Control and Prevention in 1994, they have given a criteria. They have mentioned it in a main symptoms, secondary symptoms, and signs. Main symptoms can be an unexplained severe fatigue, reducing activity level by 50%. Secondary symptoms consist of low fever, pharyngeal pain, lymphadenopathy, myasthenia, myalgia, arthralgia, sleep disorders, neuropsychic symptoms, post-exertional malaise, more than 24 hours, and some signs are low fever, pharyngitis, palpable lymph nodes. So diagnosis can be made with the help of if there is a main symptoms or at least 6 secondary symptoms or 2 positive signs, or main symptoms plus at least 8 secondary symptoms. Other one is polymyositis, which is an idiopathic inflammatory myopathies. If a patient is accompanied with skin lesion, then it can be called as dermatomyositis. So, Chinese Medical Association of Rheumatology branch have given the diagnostic criteria where they have mentioned that polymyositis have a symmetrical proximal muscle weakness, alleviated skeletal muscle enzymes, myopathic changes in electromyography. There will be a typical dermatomyositis rash, and there will be a characteristic muscle biopsy abnormalities. So, how we differentiate polymyositis with polymyalgia rheumatica? In polymyositis, we see a perifascicular atrophy, high serum creatinine kinase level, and abnormal electromyography waveform. Coming to the therapeutics and management, there is a physical rehabilitation therapy for myofascial pain syndrome. In this process of treatment, the trigger point of pain is located through the communication between physician and patient. Then, so-called biofeedback methods, so that so that the trigger point of the myofascial pain can be found. First of all, they give a extracorporeal shock wave therapy that transmits the mechanical energy to myofascial trigger points and spasmodic muscle without damaging the surrounding tissues. They uses a biofeedback to locate and treat the trigger points. Divergent shock waves relaxes the muscle and treat the superficial myofascial trigger points. And they have also mentioned about hyperthermia, phototherapy, and magnetic therapy, where there is a low frequency electrotherapy less than 1000 hertz, medium frequency around 1000 to 1 lakh hertz, high frequency electrotherapy more than 100k hertz, and phototherapy where light radiation treatments can be done, and magnetic therapy where magnetic field for analgesia and pain relief can be done. They have also mentioned something about manipulation, stretching, and kinesiology tape. Manipulation and stretching where move muscles without force or contraction to improve circulation and reduces inflammation and edema. Whereas kinesiology tape, where elastic ultra thin tape cut to shape and applied to muscle, it relieves spasm, stabilizes joints, improves circulation, and alleviates pain and edema. Now, coming to drug therapy for myofascial pain syndrome, the medication should be prescribed at the lowest effective dose and for the shortest duration to minimize the adverse effect. First line of treatment for myofascial pain syndrome is non-steroidal anti-inflammatory drug, where a common prescribed for chronic pain drugs are ibuprofen, loxaprofen, some non-selective NSAIDs, but due to their gastrointestinal issues, they have switched to selective COX inhibitors like celecoxib that reduces the GI issues. Other treatment strategies are anti-anxiety, antidepressants like duloxetine and amitriptyline. They help to manage the pain by addressing associated anxiety and depression. Coming to ion channel regulators, some sodium channel regulators and calcium channel regulators like gabapentin, pregabalin that are the first line for neuropathic pain and myofascial pain syndrome. The common side effects are usually drowsiness, dizziness, and edema. Some central muscle relaxants like tazidine, chlorhexazone recommended when NSAIDs alone are ineffective or for muscle spasm management. Last option is opioids. That is not at all a first line drugs, but it is applicable for moderate to severe pain when NSAIDs are ineffective. Coming to the other physiotherapy treatment strategies like needle punching for myofascial pain syndromes, where acupuncture and moxibustion, they have described about acupuncture involves inserting of needles into acupoints, where moxibustion is burning the warm wood, or moxibustion helps to fumigate the acupoints on the body surface to stimulate the specific part of human body. It used to relieve pain, but in a only for a short term relief, but long term results are still uncertain. Coming to silver needle puncture, they use a silver soft needle 1.1 with a heat conduction to treat interactable myofascial pain syndrome. Needle is inserted into a tender points followed by thrusting separation and heat conduction to reduce inflammation and promote healing. Another one is acupotomy, where a blade-shaped needle 0.8 centimeter wide used to cut and peel off adhesion and small nodules in a soft tissue. It enhances the local tissue activity, reduces pressure, alleviates pain, and improves the lymphatic circulation. Internal heated needle. Needle heats up to a stimulate fascia and activate the body repair mechanism. It is inserted into the fascia. It produces a controlled heat to treat the affected area. Coming to trigger point injections, the main purpose for is to treat the myofascial pain syndrome, used alone or can be used with drugged or rehabilitation. Complications can be, it can cause risk infection, some nerve injury, vital structure damage, or ensure aseptic technique and monitor vital signs. So injection for local trigger points, the procedure can we follow that we can use a finger pressure to find points causing a cord sensation, radiating pain. Injection is more effective when muscle twitching occurs. Technique focuses on myofascial points with a careful palpation for better results. They have also mentioned about USG guided therapy, where a USG helps to identify the deeply seated myofascial trigger points not visible to naked eye or not palpated during the physical examination. So the approach is used in plane or out of plane technique to elicit a local convulsive response for precise injection. Coming to neural blockade, injecting anesthetic or anti-inflammatory agent around specific nerve. It is used for provide significant pain relief by reducing nerve inflammation and muscle spasm. And they have also mentioned something about oxygen ozone injection. It is a similar to dry needling metabolized to oxygen, avoiding corticosteroid side effect. It reduces a local adhesion and systemic response. The dose for oxygen ozone injection is up to maximum 30 microgram per ml, 1 to 5 ml per trigger points, up to 30 ml per session. Recommended 1 to 3 times a week for 2 to 4 weeks. Now coming to radiofrequency treatment for myofascial pain syndrome, they have divided into thermal and pulsed. So this is a difference between thermal radiofrequency and pulse radiofrequency. They have elaborated it, but I have concised it into a small table. That thermal radiofrequency is generally continuous, but pulse radiofrequency is intermittent, where intermittent pulse is being used. Thermal radiofrequency has temperature to exit up to 60 to 90 degrees Celsius, but pulse radiofrequency has less than 42 degrees Celsius. Tissue effect is generally thermal radiofrequency is destructive in nature, cause protein denaturation and cause coagulative necrosis, but pulse radiofrequency helps in neuromodulation. Nerve destruction is occurs with the thermoradiofrequency, but pulse radiofrequency there is a minimal nerve destruction. Thermal radiofrequency is used where there is a no vital structure or nerves around the muscle, but pulse radiofrequency can be used even with the vital structure because it causes minimal nerve destruction. So coming to physiotherapy, psychotherapy and pain medicine, the importance is it addresses anxiety, depression, somatization due to long-term pain, biofeedback, hypnotic analgesia, cognitive behavioral therapy. Effectiveness is it enhances the treatment efficacy. Exercise and stretching helps in eliminate the trigger points and associate point. And education is facilitate a recovery from myofascial trigger points. So I will be discussing critic points about this article. That is, the paper generally states that the Chinese Association for the Study of Pain organized domestic experts to formulate the consensus. But the important criticism is the article does not clearly describe the exact number of consensus experts, eligibility criteria, expert selection recruitment processes, whether multidisciplinary representation existed or there can be a potential selection bias. These are the major limitation for this article. I have also described about some strength and limitation for this article. The article shows a comprehensive review overview of an etiology, diagnosis, differential diagnosis, treatment option, practical clinical oriented, multi-center expert contribution, and peer-reviewed publication. But there are various limitations for this article, such as they have no formal diagnostic criteria validated, no systemic review methodology, no Delphi or a structured consensus methodology, no evidence grading system, heavy reliance on expert opinion, mostly Chinese expert panel, limited international generalizability. As this article is usually to give an overview about the myofascial pain syndrome to the general clinician or a first line doctors to how to diagnose it and how to treat this. Otherwise, this article have many limitations. So this is all about this general. Thank you so much.
Thank you. Thank you very much indeed, Dr. Nidhi. That was a very good presentation.
Thank you,
And
sir.
I appreciate your efforts in adding in a few extra bits of information after our correspondence yesterday. That's very
Thank
good.
you, sir. Thank you,
Uh,
sir.
so look, uh, I, okay, I'm going to ask you a very basic question about this paper.
Yes.
Um, do you think this is a good paper or not a good paper?
So actually, uh, I'm about this paper. If I want to say a truth that this paper is not at all a good paper,
No.
but just for a purpose for of knowledge and for just an overview for myofascial pain syndrome. What is myofascial pain syndrome? What are different differential diagnoses and what are the basic treatment strategies they have mentioned? That's all we can get from this article. Otherwise, they have mentioned everything superficially, especially they doesn't have any evidence for the whatever they have discussed about in the article. There is a, I don't think so they have any evidence for that. So
I mean, because I mean the article. I mean, I think that yeah. I mean, I agree. I think this is a really. I think this is a very poor article indeed.
yes,
Actually, and because you could ask the question. You said, well, at the beginning when I said, I asked you to say, well, what do you think about the journal? I mean, I've never heard of the World Journal of Clinical Cases. Now, that doesn't necessarily mean that this is not going to be a good article, but it's got a very low impact factor. And whilst it purports to be a peer review article, peer review journal, this paper has got, it's got a lot of, it's got a lot of problems. So, for example, w- having read this paper and gone through it in a lot of detail, uh, do you understand what their, I mean, what their consensus view is on the diagnostic criteria of myofascial pain syndrome?
I don't think so because I have to do more research for that. I don't rely for this particular article only. I have
No,
to
no, but
compare
but
this.
but 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 even just taking the article, as a piece of information in its own terms, it purports
Yes,
to be a consensus, view on the
yes,
diagnosis and treatment. But,
yes, sir.
I mean, there is a short section in the paper which is called diagnosis.
Yes, sir.
Um, and there is a single sentence which says for the diagnosis of MPS, myofascial pain syndrome, and it says the above one and two conditions must be compulsory, while conditions three and four should be auxiliary.
Yes, sir.
The above things, I mean, they've got the clinical manifestations, which number one is symptoms and number two is signs. And then they've got the auxiliary examinations. Number one is imaging. Number two is infrared thermal imaging. Number three is
Yes, sir.
local myofascial elasticity. And number four is there is no accepted and definitive laboratory basis that can be referred to. So
Correct.
that sentence that says the above one and two conditions must be compulsory, while conditions three and four should be auxiliary, I mean,
Yes,
is
sir.
absolutely meaningless.
Yes.
And interestingly, what they do is that they do refer. There is a reference to that, which is an article that was published in Pain Medicine, which is a respected pain journal, in 2015, which was an international survey of pain management providers and a proposed preliminary set of diagnostic criteria. But the
Okay.
people who wrote this paper don't even present, I mean, they don't present those, the previous proposed criteria
Exactly. Yes, sir.
with clarity at all.
Yes, sir.
So that that's pretty poor. And then what about the treatments that what they present? Is have did I mean again, just in terms of the references in the paper, did they provide references, any high quality references for any of the treatments that they
No, sir.
presented?
They have just described it as a theoretical purpose, I think. There is no evidence or no, they have not done
Okay.
any study
Yeah.
regarding that.
Okay. So the only treatment that they
Yes, sir.
present
Yes,
for
sir.
which there is any evidence basis, certainly as far as one could ascertain from their reference list, is acupuncture. And there are two articles. There were two articles that they reference. One of which
Yes,
is a
sir.
meta-analysis of acupuncture for myofascial
Yes,
pain
sir.
syndrome,
Yes,
and the
sir.
other which is a meta-analysis systemic review.
Yes, sir.
Um, Interestingly, one of the articles that they cite as a reference for the use of oxygen ozone therapy is actually a study of fibromyalgia and not of myofascial pain
Yes,
syndrome.
sir. Yes, sir.
There is quite they cite a number of studies on trigger point injections and radio frequency treatment, though again not all of those really are targeted for myofascial pain. So, and there's a whole series of treatments that they present: extracorporeal shockwave therapy, hypothermia, manipulation, silver
Yes, sir.
needle points, acupotomy, internal heated needles. No references at all.
No
Zero,
references.
no references at
No
all.
references they have given. Yes,
So
sir.
it's pretty bad, really, isn't it?
Yes, sir.
Yeah,
I
I
agree.
mean, yeah, I mean, look,
Yes,
it's
sir.
quite, it's when we do these journal clubs, it's great to read a good, it's great to read a good paper, and it's great to be able to go through and say, look, these authors have done this properly. I think, there's a good example. I think the meta-analysis that we looked at 2 or 3 months ago
Yes,
of
sir.
some of the treatments for trigeminal neuralgia, was a very well done meta-analysis. They did it,
Yes, sir.
it was a high quality piece of, technically it was a high quality piece of work, even if the overall results weren't actually that interesting. But,
Yes,
in
sir.
terms of saying, well, did they do this? Did they do this paper properly? Did they do this work properly? They really did. This is a really shoddy piece of work that would have been, if they'd sent it to a decent journal would have just rejected it out of hand, because
Definitely.
they don't really even make an effort to to provide anything of, I mean, even as an expert consensus, they don't really, I mean, they don't even bother to present levels of evidence. They don't even
Yes,
bother to say, well, look, extracorporeal shockwave therapy is just, is expert, it's whatever level it is.
yes, sir.
So I think it's good sometimes to just read a paper and just to go, wow, it's amazing what, people can get published. And but to look at it and go, well, okay, well, actually let's take this apart. What, just for starters, this is so bad, but
Yes,
actually
sir.
just identify what haven't they done here.
Yes, sir.
Um,
Definitely.
and I think, this is, I'm afraid, one of those papers where they just haven't really
Yes, sir.
done anything at all. Um, or certainly, certainly no decent quality journal would have taken this, because there is so much that is wrong about, or poorly done about it.
Yes, sir.
Um,
Okay.
did you feel, by the time you read this, did you feel you knew more about myofascial pain syndrome?
Yeah, actually, a little bit I know more about this, but some of
Mm.
the few facts I have, like I didn't knew that is new for me, like oxygen ozone injection. I don't know about that new strategy. But after reading this article, few things, not too much, but at one to two things I knew, uh, matlab new for me. But later, other than that, this article does not have any
Mm.
proper
Yeah.
things.
Yeah,
That's what.
yeah, I think it's interesting from that point of view. And I mean, obviously, just thinking about myofascial pain, generally. I mean, in terms of what we're doing as looking after patients with headache disorders, do you, I mean, in your experience, and I'd be interested in anybody else's comments on this if they want to kind of chime in. Do you see patients in whom you would, you know, regard their headache as being a manifestation of, a myofascial pain syndrome?
Not yet, sir. I have not seen this patient, but sometimes I have one of my patient have a myofascial pain syndrome that that referred pain is there and it mimics like an headache. So initially patient came with the complaint of headache. Then later on we have done a physical examination and some palpation, and then we get to know that that is a myofascial pain syndrome in a masseter. There is a knot, that is a trigger point that we have pressed and that cause a referred pain towards the head. So patient came to the complaint with the headache. Later on we diagnosed it as a myofascial pain syndrome, and then we
Yeah.
treated it, and patient have now he's okay.
I mean,
So that's how.
yeah, I mean, it's interesting. I don't know, is anybody else on the call? Does anybody else on the call seen patients that they would regard as having presented with headaches attributable to, you know, essentially a cervical and neck-related myofascial pain syndrome? Yeah, well, the answer to that question is either no or there. Yeah.
Yes,
Hi.
we have met yeah, neck, especially mostly neck, shoulder, and some of the patients, a few patients also having the temporal muscle, they got tense and they got, yeah.
How would you distinguish, um, you know, patients, how would you distinguish somebody with a myofascial pain, myofascial pain syndrome versus just, for example, just a cervicogenic headache in more generally?
Mm. Yeah, for me, it is more like superficial and it is like muscle tender points.
Okay. Is it,
And also some patients also describe that, they have the kind of swelling, tense swelling here and there.
Yeah. Although that, I mean, obviously there are potentially a number of reasons why people might experience kind of swelling or tightness in the scalp with regard to a headache, aren't there? Um, yeah, I mean, it's interesting if you look at the ICHD criteria, the headache attributed to cervical myofascial pain. Um, that requires, I mean, those diagnostic criteria are just quite sensible. I think require a source of myofascial pain in the muscles of the neck, including reproducible trigger points, and then evidence of causation demonstrated by at least two of the following. So either the pain has come at the same time as you've got this, at the same time as the myofascial pain has started in the neck, or it's got better as the myofascial pain has improved. If you've got tenderness elicited by pressure on the muscles, and or that the pain can be temporarily abolished by local anesthetic injections or by trigger point massage. I mean, it's fairly. I mean, I think the key point, I guess, with all of this is the presence of trigger points, as you say, um, and and there is, and I think the other thing which is possibly interesting is that there is this sort of distinction between sort of tender points that you would
Tender
see
points.
in fibromyalgia, for example,
Yes.
and these taut points, which are supposed to be characteristic of myofascial pain syndrome, where there is, where there is kind of the muscle tautness and tightness, which is, I think, probably slightly different from what we typically understand as tender points in fibromyalgia. Um, Yeah, it's okay. I mean, it's very interesting. I think, I mean, obviously, all of us who see lots of people with headache disorders, I think, come to recognise the important role that the neck plays, and there are, I guess, many different ways in which pain may arise from soft tissues in the neck, and obviously, in all of those cases, those abnormal pain systems are feeding into bits of the brain, which in a fairly large proportion of the population may then generate headaches or migraines. Does anybody else on the call have any sort of additional questions or comments that they'd like to make at this point? Okay. Good. Well, look, in that case, I would like just to thank Dr. Nidhi again for her presentation, for making such a good job of such a bad paper.
Thank you so
Yes, and
much, sir.
again, and to thank you all for your attention, and to remind you that we will be reconvening again on the first Monday of next month, which is Monday the 6th of July. I think we have a volunteer for that. But as I say, anybody that would care to present future papers, and I just remind you that the purpose of the journal club is to, I mean, is obviously to present the content of the paper, but as much to critique the quality of the paper, and that so as part of a learning process for us all, in our daily kind of CPD, to kind of just get us thinking about the quality of what we're reading and how much we might want to rely on it. So, Dr. Nidhi, thank you once again.
Thank you, sir. Thank you so much, sir.
Thank you so much, sir. Thank you so much for the nice discussion.
Yeah, thank you.
We'll wind up the session, sir.
Yep.
Yes, sir.
Thank you.
Thank you, sir. Thank you.